The camera will like zoom in on different people.
Okay.
Yeah, it's moving around.
Yeah, we figured that out. We don't know if somebody moves past, they'll focus on somebody else.
Zooms in.
Yeah.
Yeah.
Is that Bentley there?
This is Bentley.
Oh, it's nice to finally. I mean, I've heard so much about him.
Yeah, pretty dog.
Yeah, he's a good boy.
Yes, that's what I was going to say. You need to introduce the dog too. They're part of the family.
We've been talking about him for all my appointments, so then now since we're actually at my house, we thought we would show you him.
Oh, that's special. Yeah. Well, we could let either Beth or Dr. Ivy just kind of introduce why we gathered today.
Go ahead, Dr.
So-
Ivy. Yeah.
Caitlin, I think you've heard some from your mom, and then maybe a little from the nurses? Or
Yeah.
I
not
don't think I don't think Kate's spoken with Caitlin, and I've not had a chance to either.
Yeah, I think your mom had mentioned it. I talked to her and she had mentioned it to you to see if it was something you would even consider. So as time goes by, they're newer medicines. Some are just an improved older medicines, and some are truly new and different. So we talked about this medicine called Sotatercept, and it's a newer medicine with a different way of acting than any of your current medicines or medicines that you might have tried before. The way it works is, imagine sort of a teeter-totter of activity in your blood vessels in your lungs, and there are some signals that are up and some that are down, and so your signaling for this one thing called PR2 is down. We know, for example, that your endothelin levels are probably high, and that's why you're on the brisafenib, right? And then your so-called cyclic GMP levels are low, so you're on the tadalafil to get that medicine up. And we tried to get those levels up. And we tried the prostacyclin, and it really wasn't great for you. I think, did we just do the sub-Q for a while, or the inhaled?
We did all of those.
There was 3 of them.
We did the oral, the
Yeah.
inhaled, and the sub-Q.
And those just weren't good for you, didn't work well, you didn't like them. So this is sort of a 4th category of medicine, and it's been studied for several years, and I don't want to get into too much detail, but even before it was used for pulmonary hypertension, it was used for increasing blood count in patients with very low blood counts. But they found that the pathway, or one of the pathways in pulmonary hypertension, is imbalanced. And so this medicine tries to so-called balance the MPR2 signaling. So it's sort of this seesaw thing. One of the high blood pressure proliferative pathways is really sort of winning the battle. And so the goal is to rebalance that and see if it will help get the pressures down and help your heart function better. Any questions so far, or I can keep going?
Keep going.
Probably 2 to 3 years ago, this medicine was being studied in adults, and they found that it was extremely helpful in some people, not all people, but the trials, they do a smaller one, and then they do a really big one, and they test it in people that are on multiple PH medications to get FDA approval. Some patients get the medicine and some don't. So we're not talking about that, but it's important to know that the Food and Drug Administration has looked at this carefully, and after looking at all of the data, they approved the medicine in March. And so it's been, well, for me, exciting because it's a different way to treat patients, and also the results are quite promising. Even in people on multiple medications, they can show additional improvement and drop in the pressure on this medicine. Just to go over what that means is that most patients on the medicine see a benefit. The pressures go down, they feel better, they're able to do more, but the medicine doesn't work in everybody, and there's some side effects that we need to talk about. The medicine is given by an injection under the skin. It's not a continuous medicine like your Remodulin was all the time. It's given as one shot every 3 weeks. We think, again, we have to look at everything, talk to hospice and home nursing. We think that can be done there and that you don't have to come here. We need to decide if it's okay to just start it there, or if we need you to come down once or twice. But in talking to the drug company, CVS, they've done home starts, is what Jess was saying. The advantage of the medicine is that it's intermittent. It doesn't require a continuous infusion and can be given under the skin with a pretty small needle. It's not associated with that kind of site pain that you had when we did the sub-Q Remodulin. So again, most people will see a benefit, but we can't guarantee that everybody is going to have a dramatic response. There are some potential side effects like all medicines. So first is that the medicine increases the blood count. So if you have a really high blood count when you start, we don't think that's a great idea. Let us look that up. I don't think yours was particularly high. That's why they check your blood count before your dosing, probably 5 or 6 times, and then intermittently. So that's to be sure your red blood cell count is not too high. And then it also can be associated with lower platelets. So if your platelets drop or your blood count gets too high, then you can decrease the dose or stop it.
We haven't checked since 2022, but her hematocrit's been around 45.
Yeah, so you haven't had a history of that, but, we wanted to talk. I think we would need to check that, make sure that we'll be okay to start. So based on your blood count, it tells us, should I keep going up on the dose or should I just stay where I am? Or some people have to wait a couple weeks and then see what happens. And so we just need to adjust the medicine to decide whether to keep going up or stay the same. People are starting this in children. We probably know of 10 or 15 that have started. But one of the problems is that you can get serious bleeding. And that's usually from the low platelets, but sometimes it's not. And so that can happen in 10 to 15% of people. So it's not minor. And the most common site of bleeding is in the gut. And so you can get something called telangiectasias, which are little sort of spider veins, spider arteries, little clumps of vessels, and those can be fragile and bleed. And there have been bleeding in the gut for people. If you had serious bleeding, we would consider an endoscopy to look and see why you're bleeding and then decide whether or not to stop or keep going. I don't think you're on any blood thinners, right?
No.
And I don't think aspirin either.
No.
In a way, that's good because that increases the risk of bleeding. So I think not being on any blood thinners or aspirin is a good thing. And to be totally honest, there's one elderly lady who had some bleeding in her brain and passed away. I mean, it's a very small chance, particularly in you since you're much, much younger and not on any blood thinners and not on any prostacyclin, because that can make you more likely to have some bleeding. So I think the chance is low, but I can't tell you it's 0. So we think more likely than not you would have a beneficial effect. We can't really say how much of an effect. Is it going to be dramatic? Is it going to be, a little bit, or is it not going to be any? We haven't heard of it making people worse. So we just thought that since you, the last year or two has been really tough and you've been not doing as well, that we wanted to just talk to you about it. I don't know if you've had a chance to look it up on the internet. I think that's mostly what you're going to find on the internet is the general positives. You need to check the blood count and platelets before you do a dose for a while. And then the nurses and the companies have been working to get this done at home for a lot of people rather than coming down to Denver for you or going to a doctor's office. And over time, I think a lot of people do this on their own. But if the home health nurse could do it or you guys could learn to do it. It's not that challenging, but we would just have to stay in close contact.
I think if I could stick you
Jess,
with
do
the
you want
sub-Q,
to add
I could
anything?
give you an injection.
I did speak to the CVS specialty pharmacy nurse yesterday, and they're happy to teach whoever. They cannot actually give the medication, but they come in, they would do in-person teaching and can do multiple sessions. And just with how the medication is, you might have to draw up a couple of vials, but they give you lots of education on that. So, like Dr. Eddie said, it's under the skin. People have been giving shots underneath the skin for a long time at home, so that's technically not hard, but it's just making sure you mix the med and draw up the right dose, I think is the biggest safety in terms of drawing up the medicine.
We're professionals, right?
I just wanted to be clear too that the team has worked really hard in making sure that this is covered. I don't know if we just kind of grazed over that, but it is covered through your insurance, and we've gotten approval for that. So just wanted to make sure you knew that too.
Jenny, do you know, have we put it through far enough to know what Medicare Part D would pay and what their copay would be? Because Kate
I
had
don't
some
know.
questions about that. that.
Yeah, I don't know about the copay part, just that it was approved.
Yeah, I don't have that information. We'd have to reach out to CVS to find out. It's a newer med, as Dr. Ivy said, and so, insurance is always slow to add different meds to their formulary, and we had a different patient with a different type of insurance, and they had a really high copay, so I do think that's something we need to follow up on, and happy to do that. If that's especially if that's a decision factor for you.
I think before we start, we'd obviously want to know what the copay was.
Yeah.
But we wanted to talk to you before we got too far down the road to see what you were thinking, what questions you had. We don't want to push something on you. We want to give you the information you need to make a decision. And like your other meds, if you start it and don't want to take it, we can stop it.
So the blood draw stuff, like how often does that happen?
We need to check because the
Sure.
rules change a little. In the trials, I think they were doing the blood count, just one blood test, a CBC, a couple days before the dose for 5 doses. Now that seems to have changed a little and that they might be doing fewer. I think we'd want to stick with 4 to 5 and then maybe every second or third. And some of that depends on what the trend is. If the platelet levels are going down, we want to check it more frequently. If the blood count was really going up, we might check it more frequently. When you look at what the FDA approved, it says for the first 5 doses. So you would check it before. And luckily, I think the team up there are willing to do that at your house. Is that right?
Yeah, from a hospice perspective, I'd be happy to come in and do these lab draws and learn and help administer injections, help with this teaching, those kind of things. But that would be where I could be most useful, I think, from being a nurse in the home. Yeah.
And then I guess we'd have to see, you think CVS would go out the first couple times or?
They said they can do up to 3. If needed, they can do more. The biggest thing that they've seen so far is you do start at a lower dose, and then as long as you're tolerating that, we do increase after the first injection. And so sometimes, depending on your specific dose, which is based on your weight, that might entail a little drawing up 2 different vials. So that's like the biggest reason they go out for at least a second visit.
So we're not asking you to make a decision right now. We just want to give you the information and see if you have questions.
If she starts this, does she continue hospice care? Because that's going to be a deciding factor, I think, for her.
We have had preliminary discussions with hospice, just making sure that that would continue, because we hear that that's a really important benefit, especially with Beth being the nurse that would help you with the injections and with the labs. And so yes, this is a medication that is approved in addition to your hospice benefit, similar to the other medications that you're on that hospice helped you get covered actually when you started hospice. So yes, that was something that we already looked into and checked with hospice about.
And I would anticipate, for right now, this is the way it would be. I don't think we have to say a year and a half from now.
Right.
We can say for right now, absolutely, I'm here. And let's just see. If that's the direction you want to go, Caitlin, then I'll support you in any way that I can.
And that might be one of those things where if you do decide, and when we do the injections, that's the 5 days that you get to stay in-house so that there's somebody there round the clock.
I think that's a great idea. Michelle's talking about bringing her into our inpatient unit if ever necessary for a little bit increased observation, and we would have that absolutely as an option as a part of her benefit too.
When I think about the symptoms and side effects that could sound concerning when we talk about the bleeding piece, that's a benefit of hospice, right? And then they have an inpatient unit so that you wouldn't have to go somewhere else. You could go there potentially for that too, I'm hearing. I just want to clarify with that.
Yes, we could bring her into our inpatient unit if ever needed. That's all, wanting to present that as an option, and I'm absolutely 100% saying, yeah, we can help. If it would be a more comfortable situation for her to be monitored with nursing around the clock for her first injection or whatever Caitlin would feel most comfortable with, we'll accommodate.
So probably like all of our visits, Caitlin won't say anything until we hang up, and then she'll ask you guys a lot of questions. So.
And then we'll follow up with you, Dr. Ivy.
That's what I'm expecting. And then, again, it's really up to you. We want to try to help you, but it's really up to you. So as much information as you need. We really know you don't want to drive to Denver every 3 weeks. And so I know that's really important. I think we can work all of those things out.
Caitlin, I can try and plan to give you a call early next week to give you some time to think about it, if that's helpful.
Yeah.
Was that a yes?
Yes.
Okay. This is a lot of information to take in, and so we don't want to rush you by any means. This decision's totally up to you, and as Dr. Ivy keeps saying, we wanted to make sure you were aware of a new therapy that's out there that, you know, isn't as intensive as like the inhaled or the years or IV.
Any of those?
Yeah.
Anybody else have any questions?
I think those are my questions. Yeah, so I guess we'll talk to you next week and see how this week goes and do some chatting and see what she thinks is best.
Sounds good.
You know, if you have questions between then and now, let us know.
Sounds good.
Do you guys know how best to reach them? I know you're just not in communication as often as you once were. Do you have questions about how to reach Dr. Ivy?
I know how to reach that guy.
Perfect.
You've had 2
Many
years of
years.
experience.
Many years.
Good, good.
All right. It was great seeing you guys and talking to you. So let us know and we'll chat next week.
Perfect.
Sounds good. Thanks.
Thanks for taking the time.
All right. Bye.
Bye, guys.
Bye.